So my name is Brenda Kenefick, and I'm with the University Health Network in Toronto, Canada. And I'm going to take you through the story that I've been through, but I want to give you a little bit of my background. I've been in manufacturing for 20 years. So I've made onion rings, I've made French fries, I've worked in trucking, I've worked in courier, and about 4 or 5 years ago, had a little midlife crisis and quit work and took some time off and moved over to healthcare. And the reason was because I wanted to do something that I thought was truly impactful and meaningful. And I did not know it would be such a huge learning experience. So very quickly, University Health Network is the largest academic research hospital in Canada. It's based in Toronto, and there's 4 hospitals in the system. I'm going to tell you the story about reducing pressure ulcers in the spinal cord patient population, introducing teams to proactive versus reactive management, and the power of transparency. So when I got into University Health Network, one of the things I said to the senior leadership team is, you know what, I'm talking about lean, and you have no idea what I'm talking about. So we all got on a plane, and we went out to Seattle to see Virginia Mason and to see Seattle Children's Hospital. It was very eye-opening, and when we came back, they said, let's launch in the spinal cord patient population for 2 reasons. One, we had just integrated with Toronto Rehab Network, and the spinal cord patient population goes there. And the second was, it's a nice confined patient population.
Just 1 second. I think to be fair to our speaker, we really need to fix the mic. And you could use this up here if this is
It's my badge?
I think the chain is
Okay.
They can do it?
Oh, unchained at last. Okay.
Well, let's see if this works. We've got
Okay. Thank you very much. So why do we care about pressure ulcers? Well, we did our value stream typically, and one of the things that came out was one of the things that prevents flow is spinal patients get pressure ulcers. And if you don't know what that is, they're big, ugly wounds from not moving around enough. And Christopher Reeve, actually, who played Superman, died from a pressure ulcer, so they can be fatal. So, and they're hugely expensive, as you can see. And we've been working on them for 10 years at UHN. So they have a healthy skin committee, and they've done audits, they've done initiatives, all kinds of things. And after 10 years, they concluded we haven't made any impact on addressing pressure ulcers. So we said, okay, let us help. So our second rapid improvement event was pressure ulcer reduction. And we don't use PDCA because when I got there, everyone knew exactly what it was, and they all did it, and we weren't anywhere. So we introduced what came to be known as the Circle of Love. And it starts with goals. So we said the first thing we have to do is our goal in this rapid improvement event will be 0 pressure ulcers developed. That's important because people do arrive with pressure ulcers. Let's focus on we don't make people sicker. The first day of the rapid improvement event, we took the team. It's very interprofessional. We have nurses, we have physiotherapists, allied health nutritionists, and we went out and we did an audit to find out where we are exactly. And they did the audit on 3 different units, and they said 50% of the required testing is not done, so looking at people's skin. We don't have a care plan, and 14% of our patients have pressure ulcers. So we said, okay. The team was very upset. They said, that can't be right, we don't buy it. So ended Monday. So Tuesday we came back, and the team was still very upset, said that can't be right. So what we did is we said, fine, let's go do the pressure ulcer audit again. So we went out and picked some different patients and did the same audit. And lo and behold, we got exactly the same numbers. So we were very clear where we were. But what happened, the second audit, was I was standing there, and I'm new to the organization, so I don't know people. And 2 of the 3 managers of the units we're looking at took me aside separately, sat me down in their office and said, you're totally wasting your time, we don't have a problem. Why are you here? So we had a nice little conversation about that. And then when I was standing there, there was some staff not part of the rapid improvement event who basically were talking about a patient that was very high risk, was refusing treatment for pressure ulcers, was going to get sick, and quite possibly, really bad things were going to happen. So we went back to the rapid improvement team, and we talked about the results, and they were very angry and whatnot. And then I told them about these stories about, this person who's at risk, and does anyone know about it? And they all knew about it. And I said, so what do you do about that? And they said, what do you mean? We did everything we're supposed to do. We're healthcare professionals. We followed our college guidelines. We're done. They said, but the person's still not well. So here's an advantage going into healthcare. You can ask questions. You're thinking, what are you talking about? So we talked about it, we talked about it, we talked about it, and then it came out that we don't believe in escalation. What is a manager going to do about it? So that evening when we had our little management debrief, I had already talked to the vice president who came to the management debrief with the clinical director and then the frontline managers, and we talked about the situation. And I knew I was in trouble when the vice president stood up from her chair and went and stood behind her managers. And I thought, okay, that's not a good symbol move there. But we talked about it, and they had been actually out to Winnipeg to see a manufacturing company where they'd seen the idea of pull the cord. So we went back to the team, and the team talked and talked and said, okay, this is what we're going to do. And we got the team involved in saying, you can be angry or we can try to do something differently. So what they did was they said, we're going to change how we address these. So basically the standard care form. We're going to put in a daily huddle board, which was the first time we'd introduced them, where the manager every single day was going to ask, have you done your Braden, which is a skin assessment? Have you implemented your correct standards of care? Did someone arrive with a pressure ulcer? Did someone develop a pressure ulcer? And every day we're going to ask these questions. And we're also going to put something in, if someone does develop a pressure ulcer, we're going to pull the cord and see what happens. So we implemented this. It was very difficult to do. Not because the managers were unwilling, but mostly because they had never had an expectation of going out and talking to their staff every day. And in healthcare, most metrics are 3 months out of date before the frontline manager sees them. So this was a very different approach for them. So what happened? Pressure ulcers went down from about 14% to they're averaging around 5 or 6%. People do arrive with pressure ulcers, so we're not really addressing them. But they also have updated this now that they know all their high-risk patients, and they can really think about how can we prevent this and changing the role of the frontline nurses to prevention and changing the role of the managers to we actually have to fix these problems as they come up and thinking differently about how they do their work. We've started to get lots of pull. So we started with 3 units. We partnered with the Healthy Skin Care Committee under the guise, so their goal is we're going to reduce pressure ulcers by 10% over 3 years. And I said, I'm not getting involved with that. We're either going to go for 0 or, you're on your own. So they said, okay, but that's totally unrealistic. I go, I get it's totally unrealistic. I don't care. We're still going to go for 0. So we're down up to 7 units, and we went to 11 units. We've done it very, very rapidly in terms of healthcare. So one of my great learnings here is we give the training, and I think they're going to start right away. But then they say, well, we've scheduled it, and we're going to start in 2 months. I'm like, are you kidding me? So that's one of the things we've gone back to the steering committee to kind of say, why does it take that long? But they're getting going. So, and now we have actually something I stole from LEI conference last year was learning communities. So we bring people in, the manager of the units that are up and running, and we just have them talk about what's working, what's not working. I can tell you that after 14 months of doing this, the standards of care, so how nurses actually treat patients, they're still talking about what they should be. So there's lots of learning going on. And in a hospital, you have operations and you have practice, and the two don't talk. We're forcing them to talk and try to come together on that. And now managers know their numbers, and very seldom does a pressure ulcer go past the stage 1, which is very, very positive. So what are the lessons? Improve the work, be very clear on the process. So who's accountable for doing what, and make sure people understand. And in our case, we said, let's have the manager ask every single day, have you done it? So it's not insulting, it's just very important. Keep score and celebrate often. So we have a little star up when we get to 10 days, 20 days, 30 days. We bring in milk and cookies and that sort of thing. So people want to celebrate good things. And improvements must be owned by the team. So there are wound care resource nurse experts that used to, whenever someone had a wound, they'd just say, well, you take care of it. Now they're bringing that knowledge in. On the developed people, leadership has to be open. They need to really acknowledge that there is issues and be able to see them in the current system. It's hard to know what the numbers are. Prevention is better than treatment. To lay people, that seems very, very obvious. If you're in an acute care hospital, you're totally into treatment, right? They're not big into prevention, so it's a big change in mindset. And healthcare is very task-focused. People in their college, I need to do this, I need to do this, I need to do this. to talk about this is what the process looks like, the process of prevention, is a huge change. And healthcare culture may not support escalation. Just a very quick footnote, the patient that was refusing treatment and wasn't doing well, we brought the most responsible physician into the room. And we told him the story, and the physician, as he would, and he's a surgeon, by the way, said, I'll take care of that. And he stood up, walked into the patient's room and said, listen, I'm told you're not doing this. I need you to do this from now on. And that patient is much better. So that's the power of the doctor. But I have to say, we still don't have the doctors on our side entirely. And that's our story at UHN.
Okay, well, stay right here.
Yep.
Stay right here. I'll get myself. Thank you. I'm certainly, when I get my pressure ulcers, I'm heading straight for Toronto.
Yeah.
Except I don't want to be one of the 6%. So, look, interesting question. That was a very interesting story. You came in as the outside team,
Yep.
right? And the lean team is going to show up and make things all better. The doctor is in the house, okay? So we looked at the chart, and you got from the high point down to the low point.
Yep.
And then toward the end of that chart, it started to hook up again. So here's the question, look for all of us, about sustainability. So what's your thinking, and where's this all lead?
Well, my thinking is, I don't like the word sustainability, because I want to get better all the time. Part of that little hookup is because they've taken the same thing and started working on falls prevention. So they've expanded it. And they've also, you know, like anything, it goes up and down, and they've lost focus, and we refocus. So we don't like to see that, but,
Well,
you know.
okay, well, let me generalize the topic, though. I would, in my life, have learned that basically things do love to regress to the mean. Okay, this seems to be some law of the universe. Things love to regress to the previous mean. And the only thing standing between that, well, the only thing preventing that is some sort of management system that prevents that. So just as you're looking ahead at Toronto, hey, look, great story. Well, didn't get to zero, but you got halfway.
Yep.
Okay, so just to maintain halfway, what's going to be required? Then the other half is, okay, now, wait a minute, class. We said, what, 10% over 3 years. You said half in a few months.
Yep.
So now, about that zero, that perfection thing, what's the next step?
So the next step for us is we're kicking off management training, because we do need to get engaged broader on problem solving and getting people really understanding it's fine to run this particular huddle, but how does that translate to the rest of the organization? And the pull to start working with other committees to try and teach them new approaches. If it's all reliant on us, it's never going to work. So it's training other committees to take this idea forward and have them run with it.
Yeah, okay.
Yeah.
By the way, just one final thing that goes with that, the interesting issue of escalation. Mark's going to be up in a minute next and talk about healthcare. Oh no, you're two out, but we'll get, the healthcare theme is here. You were taught as a doc that you should not make mistakes, that if you do something quick, whatever you do, don't stick your head out in the hall and say, hey, I think I've screwed up. Anybody got any ideas? By the way, I went to the doctor once at MIT many years ago, and the guy stuck his head out in the hall. The doc screamed down the hall, does anybody know anything about malaria? and I thought, this is good. This is good, because the way he probably had done it before was to say, oh, well, malaria, and then he would get the Merck manual out and, you know, do whatever. But look, this is a real issue. That you saw at the beginning a desperate desire to suppress symptoms, right? That you walk in and say, half of your folks have got bed sores, and they say, no, that can't be true. We're a great hospital. You know, we're one of North America's finest, so that can't be true. Well, here we are, that you've gone through the initial barrier of denial that there's an issue, but now things will continue to go wrong. So just what you've learned about how you basically get people to embrace the idea that announcing problems is a really good thing.
Definitely, you know, transparency and being able to see what's going on. And so when we actually teach huddles now, the first thing we do is as soon as someone says, no, I didn't do that, the only two acceptable words are thank you. thank you for telling me, thank you for letting me know, and let's move on from here. What can I do to help? And it's really getting problems visible, and it's not because you're a bad manager, it's not because you're doing a bad job, but by doing that, we might be able to prevent that problem for the next patient. And the advantage in healthcare is you can actually bring the patient into the room and have them tell you their experiences, and so it makes it very real.
Okay, well, look, for all of our sakes, because we're all going to wind up having to deal with these folks at some point, I hope you're right, and I hope things continue to go down. I don't mean heart rates or brain waves, I mean defects. So thank you for your good work. Thank you.